Before using a powerful appetite-suppressing medication for weight loss, should we first consider supporting the metabolic problems contributing to weight gain? Berberine is sometimes called nature's Ozempic, but I do not believe that is the best way to describe it. Berberine and semaglutide are not the same, and berberine does not need to imitate Ozempic to have value. As a naturopath, I am interested in berberine because research suggests it may support blood glucose regulation, insulin sensitivity, cholesterol, and other metabolic markers. In this video, I will explain why berberine may be worth considering in selected cases, and why the side effects and long-term implications of GLP-1 medication should not be ignored. When someone wants to lose weight, I do not begin by asking how to suppress their appetite. I begin by asking what may be driving their weight gain. Is there insulin resistance? Are blood glucose levels unstable? Is sleep affecting appetite and cortisol? Is thyroid function appropriate? Is the person eating enough protein and fiber? Are stress, medication, menopause, or digestive problems contributing? Reducing appetite may help someone eat less, but it does not automatically correct every underlying problem. In suitable cases, I prefer to work on the metabolic foundations before considering a treatment that may need to be continued long-term. Berberine is a bioactive compound found in plants such as barberry and Oregon grape. It has a long history of traditional use and is now being investigated for several metabolic applications. Research suggests that berberine may influence glucose metabolism, insulin sensitivity, blood lipids, inflammatory pathways, and the gut microbiome. This makes it particularly interesting when a person has metabolic dysfunction, not simply a desire to lose several kilograms quickly. I do not view berberine as a miracle fat-burning supplement. I view it as a potentially useful therapeutic tool when there is a clear reason to use it. Systematic reviews have reported modest reductions in body weight, body mass index, and waist circumference with berberine. A 2025 meta-analysis of randomized trials also found a modest improvement in BMI, although the average effect was relatively small. Research has also reported possible improvements in fasting glucose, insulin resistance, triglycerides, and cholesterol. However, the studies vary in quality, duration, dose, and participant health. A recent 6-month randomized trial involving 337 adults with obesity and fatty liver found that berberine did not significantly reduce visceral fat or liver fat compared with placebo. However, the study found reductions in LDL cholesterol and some inflammatory markers, and berberine did not produce an excess of serious adverse effects compared with placebo. This is a good example of why I see berberine primarily as metabolic support, not as a rapid weight loss drug. Ozempic directly activates GLP-1 receptors. Berberine does not. Its possible benefits appear to involve several metabolic pathways rather than powerful appetite suppression through one pharmaceutical target. This difference can be an advantage for someone who does not require medication-level appetite suppression, but may benefit from broader metabolic support. A slower change is not necessarily a failure. Gradual weight reduction, combined with improved food choices, strength training, and better glucose control, may be more sustainable for some people. The goal should not always be the fastest possible weight loss. The goal should be improved health that the person can maintain. Ozempic contains semaglutide and is prescribed primarily for adults with type 2 diabetes. Wegovy also contains semaglutide, but it is specifically approved for chronic weight management in eligible patients and generally uses a higher maintenance dose. Social media frequently calls every semaglutide treatment Ozempic. When discussing weight loss results and side effect statistics, many of the commonly quoted numbers actually come from Wegovy trials using the 2.4 milligram weight management dose. This distinction matters because dose, indication, and individual health can influence both results and side effects. The gastrointestinal side effects of weight management dose semaglutide are often described as mild or temporary, but they are common. According to prescribing information based on adult weight management trials, approximately 44% of participants taking semaglutide experienced nausea compared with 16% taking placebo. 30% experienced diarrhea compared with 16% taking placebo. 24% experienced vomiting, compared with 6% taking placebo. 24% experienced constipation, compared with 11% taking placebo. 20% reported abdominal pain, compared with 10% taking placebo. This does not mean every person will experience these symptoms. It does mean that digestive side effects are a major part of the risk-benefit discussion, not an unusual possibility. In the same clinical program, approximately 6.8% of adults using weight management dose semaglutide permanently stopped treatment because of adverse reactions. The placebo discontinuation rate was approximately 3.2%. Nausea, vomiting, and diarrhea were among the most common reactions leading people to stop. Persistent vomiting or diarrhea may contribute to dehydration, which can place additional strain on the kidneys. Severe constipation may also significantly affect quality of life. These risks do not mean that the medication should never be used, but people deserve to know the statistics before assuming that an injection is an easy solution. Semaglutide prescribing information also includes warnings about acute pancreatitis and gallbladder disease. In adult weight management trials, gallstones were reported in approximately 1.6% of semaglutide-treated participants, compared with 0.7% receiving placebo. Inflammation of the gallbladder was reported in approximately 0.6%, compared with 0.2% receiving placebo. Rapid or substantial weight loss can itself increase the risk of gallstones, but the prescribing information notes that the incidence remained higher with semaglutide even after accounting for the degree of weight loss. Persistent severe abdominal pain, particularly when it radiates to the back or is accompanied by vomiting, requires urgent medical assessment. Semaglutide can slow stomach emptying and may not be suitable for people with severe gastrointestinal disease. Its prescribing information includes warnings and precautions relating to pancreatitis, gallbladder problems, kidney injury associated with dehydration, diabetic eye complications, and hypoglycemia when combined with certain diabetes medicines. Semaglutide products also carry a boxed warning concerning thyroid C-cell tumours observed in rodents. It is unknown whether this effect occurs in humans. The medication is contraindicated in people with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. This is why semaglutide should be prescribed and monitored, not purchased or used casually. Another important limitation is what happens after semaglutide is discontinued. In an extension of the Step 1 trial, participants regained approximately 2/3 of their prior weight loss within 1 year of stopping semaglutide. Many of the cardiometabolic improvements also moved back toward baseline. This suggests that for many people, semaglutide may function as long-term treatment rather than a short course that permanently solves weight gain. This should be discussed before treatment begins. Can the person access and afford it long-term? What is the plan for preserving muscle? What happens if the medication is stopped? What lifestyle and nutritional habits are being developed while appetite is suppressed? When body weight decreases quickly, the loss may include both fat and lean tissue. If appetite is strongly reduced, some people struggle to consume adequate protein, fiber, vitamins, and minerals. They may lose weight, but also feel weaker, more tired, or less able to exercise. From my naturopathic perspective, preserving muscle is essential. Muscle supports metabolic health, physical independence, glucose disposal, and long-term weight maintenance. Anyone experiencing significant weight loss should pay attention to protein intake, resistance exercise, hydration, bowel regularity, and nutritional sufficiency. A lower number on the scale should not come at the expense of strength and health. In an appropriate person, I may consider berberine before GLP-1 medication when the main concerns include early insulin resistance, unstable blood glucose, elevated triglycerides or cholesterol, and modest weight gain associated with metabolic dysfunction. This would be part of a complete plan, not a replacement for nutrition and lifestyle. I would also consider laboratory results, current medication, digestive tolerance, liver and kidney health, pregnancy status, and the person's overall clinical picture. Berberine may offer a gentler starting point for selected people, particularly when rapid appetite suppression is neither necessary nor appropriate. However, medication may still be the right option when obesity or diabetes is more advanced, or when the expected benefits clearly outweigh the risks. Supporting berberine does not mean pretending it has no risks. Berberine may cause nausea, bloating, constipation, diarrhea, or abdominal discomfort. It may interact with medicines, including cyclosporine, and may add to the glucose-lowering effect of diabetes medication. It should not be used during pregnancy or breastfeeding, and it must not be given to infants. Supplement quality is also important. Unlike prescription medicines, supplement quality and potency may differ between brands. Choose a reputable, independently tested product, and seek professional guidance, particularly if you take medication or have a diagnosed health condition. Consider two people who both want to lose weight. The first person has mild insulin resistance, irregular meals, inadequate sleep, and a sedentary lifestyle. This person may benefit from nutritional changes, strength training, improved sleep, and carefully selected metabolic support such as berberine, if it is appropriate for them. The second person has severe obesity, poorly controlled type 2 diabetes, and a high cardiovascular risk. For this person, prescription medication may provide clinically important benefits that should not be delayed by supplements alone. Naturopathic medicine should be personalised. Standing for natural medicine does not mean ignoring when medical treatment is necessary. My preferred approach is to begin with the least intensive option that is likely to be safe and effective for the individual. First, identify the metabolic drivers. Second, improve food quality, protein, fiber, movement, sleep and stress regulation. Third, consider targeted natural support, such as berberine, when there is a clear therapeutic purpose and no contraindication. Then monitor symptoms and objective markers such as glucose, insulin, lipids, waist measurement, and body composition. If these measures are insufficient, medication can be discussed with the person's doctor. This is not about choosing nature against medicine. It is about not escalating treatment before understanding the person. Berberine is not a natural version of Ozempic. It is a different metabolic tool with potential benefits for blood glucose, insulin resistance, cholesterol, and inflammation. Its direct weight loss effect is generally modest, and recent research reminds us that it will not reduce visceral or liver fat in every population. However, its value may lie in supporting metabolic health without producing the same degree of appetite suppression or the same side effect profile as semaglutide. Weight management dose semaglutide produces substantially greater average weight loss, but common digestive side effects affect a significant proportion of users, and weight regain frequently occurs after treatment stops. For selected people, I believe it is reasonable to explore foundations and appropriate natural metabolic support before progressing to more intensive medication. The right choice must still be based on evidence, medical history, and individual risk. If you found this balanced naturopathic perspective helpful, subscribe for more practical, science-informed natural health education. You can also explore my course, Heal Your Body Naturally, where I explain how food, digestion, hormones, stress, sleep, and lifestyle work together. The link is available in the description. And tell me in the comments, would you like my next video to explain how berberine may affect blood glucose, cholesterol, and the gut microbiome?